ladies and gentlemen, we're going to introduce our third and last speaker, and this is Dr. Adel Hussien. It's our honor and pleasure to have him with us tonight in this extraordinary session about intensive care medicine. So Dr. Hussein is a former associate professor of critical care medicine in Cairo University. He is also a former director of critical care medicine in King Abdullah Medical City in the Holy Capital in Saudi Arabia. Dr. Hussein has achieved an MD and PhD degree from Cairo University. He is currently working in King Abdullah Medical City in Saudi Arabia. Today he is going to give us a presentation about arrhythmia overview. Welcome, Dr. Hussein. Please go ahead. Thank you.
Thank you, Dr. Mona, and I am glad to this opportunity to be with you. My presentation today is the arrhythmias for the intensivist. I have nothing to disclose. Regarding the arrhythmia for the intensivist, it's difficult to cover in one lecture. So what gonna we do over the next lectures or the next weeks or the curriculum of this awesome mega online course, that we will make it like a series. And this is the series structure and outline for the arrhythmias. As I told you, it's difficult to cover in 30 minutes or 45 minutes or on one lecture. So usually it's a course. It's usually a course, or arrhythmias usually is a course. So the lecture or the structure and the outline for this series today or tonight, I will give you a highlight about the arrhythmia overview. Second lecture will be bradyarrhythmias, differentiation and management. Third lectures will be supraventricular tachycardia or SVT, differentiation and management. The fourth lecture will be ventricular tachycardia, differentiation and management. And the last lecture, or the fifth one, will be patient ECG troubleshooting. So those will be the 5 lectures covering the arrhythmia series for the intensivist. I will present it from the intensivist point of view. I will not go deeply through pathophysiology or underlying electrophysiology. It's just like an intensive care physician, how he will deal with the arrhythmia, how he will identify the arrhythmias. So it will be like 5 lectures every week, according to the organization. They will choose which coming week, so we will go in the series. So tonight, inshallah ta'ala, I will start with the arrhythmia overview. So all of us, we know that cardiac arrhythmia occur frequently in critically ill patients. The most common arrhythmia overall is the sinus tachy. Atrial arrhythmia also occurs some frequency, whereas the ventricular tachyarrhythmias are less common. So commonly is the atrial arrhythmias, less common is the ventricular arrhythmias, but usually is more ominous. Note arrhythmias seen in the ICU settings are of new onset, distinguishing chronic heart block and underlying pacemaker. So those arrhythmias that can be exacerbated by their critical illness. So for example, the patient had already a chronic AFib or paroxysmal AFib, then he was admitted to the ICU, he's shocked, or he had sepsis, so he has AFib with rapid ventricular response. Or he had new ischemic event, or he hypoxia, so he got a new arrhythmia or exacerbation of his chronic arrhythmia or previous arrhythmia. As we talk about the sinus tachy, I told you that the sinus tachy, one of the commonest arrhythmia that you will counter in the ICU. Many underlying or many contributing factors underlying for the sinus tachy. Most of them is like the physiologic causes of sinus tachy, like the fever, the pain, the delirium, the anxiety, inappropriate sedation in ICU, or endocrine causes like hyperthyroidism, pheochromocytoma, the autonomic dysfunction like the nicotine, withdrawal, thromboembolism drugs, cholinergic, the alcohol withdrawal, inadequate cardiac output for patients with hypothyroidism, volume losses, sepsis, patient with tamponade, PE, Q syndrome, hypoxia. So there's a heterogeneous group contributing factors for one entity, which is the sinus tachy. So you can imagine, how can we manage sinus tachy in the ICU? So when you face it, so please, you have to look for the underlying cause of sinus tachy, because your patient is giving an idea why he's having sinus tachy. So when your patient is having sinus tachycardia, for example, this is something still benign, but it tells you a message that you have searched behind the cause of sinus tachycardia. Arrhythmias are most likely occur in patients with structural heart disease. So this is the commonest find that patients with underlying structural heart disease, they have arrhythmias. The management of arrhythmias usually includes correction of the imbalances, usually, as well as the medical therapy directed to the arrhythmia itself. So for sure, management of atrial fibrillation or atrial flutter, different than management of ventricular tachycardia, different than management of bradyarrhythmias. So your management should be directed to the arrhythmia itself in a matter of the precipitating factor, the underlying cause, and the lines of therapy. The urgency and the type of treatment usually is determined by the physiologic impact of the arrhythmia, as well as the underlying cardiac status, underlying ejection fraction. So this is identify probably the line of therapy when you intervene to terminate the arrhythmias, plus the hemodynamic profile. The arrhythmias in the ICU, as all we know, it represents a major source of morbidity as well as increased length of stay. And of course, this is two common factors contributing to ICU morbidity, plus prolonging the length of stay of the ICU to manage the arrhythmia in the ICU. What about the overall incidence for arrhythmia? It's a very wide incidence. As you can see here, it's from 15% up to 70%. This is the overall incidence of the arrhythmia with different types. Those are the different types of arrhythmias between ventricular, supraventricular, AFib, bradyarrhythmia, sick sinus, and others. So those are the wide spectrum of arrhythmias in the ICU between ventricular tachycardia, SVT, atrial atrial flutter, bradyarrhythmias. So it's a very heterogeneous group or very heterogeneous types of arrhythmias in critical ill patients, as we will see. What about the incidence and the impact of arrhythmias on patients in ICU? This is one study, concluded the impact and as incidence, and impact of different type of arrhythmias. For SVT, so the incidence in that, this was a Japanese trial or meta-analysis, and this we found the incidence was about 8%, while for sustained VT was about 2%. For conduction abnormality was 2%. When we went through adjusted in hospital death rate, it was close to 30%. This was unadjusted care. For VT was about 73%. For conduction abnormalities was about 60%. And neurological sequelae like strokes was 15%, and SVT for VT was close to 38%, while for conduction abnormality was about 70%. But the overall after adjusting the prognostic factors and propensity scores, they found that, interestingly, that the ventricular arrhythmia increased the mortality in ICU patients. The mechanisms of arrhythmias commonly in ICU, either we have structural facts or transient facts. Those are the two major mechanisms in the background of inducing the arrhythmia or arrhythmia happening in the ICU. So, for example, I have structural risk factors like MI or myopathy. So this is a risk factor or inciting factor for abnormal automaticity, then premature atrial or ventricular contraction. Then the patient will develop arrhythmia, either atrial or ventricular. On the other hand, if you have transient risk factors or influences or inciting factors, like transient myocardial ischemia or some systemic facts like hypoxia, acidosis, electrolyte imbalances, or electrolyte disturbances like bulimia, hypomagnesemia, or neurological factors like autonomic dysfunction, or some pro-arrhythmic effect of the drugs also were risk factors for the development of arrhythmia. So remember very well, for the mechanisms, you have structural risk factors related to the heart, or systemic or transient influences, which is reversible or also can be treated when you look for the arrhythmias. So why we are interested in the arrhythmia identification and management? First of all, we mentioned that in the previous slide, remember, because of the increasing morbidity and the length of stay. And those are the sequelae that usually we found when we study or to monitor with arrhythmias. This is one of the devastating sequelae of arrhythmias is the systemic thromboembolism, and this is the stroke, or bowel ischemia, or heart block, or requiring for permanent pacing. Regarding causes of arrhythmia in the critically ill patients is a long list. It depends, as we mentioned previously, on the underlying mechanisms. So for bradyarrhythmia and for tachyarrhythmia, also there is two major groups of underlying mechanisms. So arrhythmias that arise from primary cardiac diseases is a bradycardia or tachycardia, so a long list, or arrhythmia that are arising or happening secondary to systemic diseases or transient risk factor, transient inciting factors, like I mentioned before, like the hypothermia, the hypo or hyperkalemia, the high ICP, the drug toxicity, the hypoxia, the acidosis, cytotoxicus. So those are the common causes. Yes, it's a long list, so it should be in your mind when you're reviewing your patient who is developing new arrhythmia in the ICU. What about the classification of arrhythmias? So we have been taught frequently how to classify the arrhythmia. So commonly, the arrhythmia either brady, very simple, or tachy. And this, it depends on the rate. When you go for brady, this is a heart block with its different types, or just simple bradycardia like sinus bradycardia or sinus or sinus arrest, or whatever the underlying cause of bradycardia or tachycardia. Going for tachycardia, then you have to with narrow-complex based on the width of the complex, either than 120 milliseconds or more than 20 milliseconds. So either narrow-complex tachycardia, and these are the common entities. Wide complex tachycardia, this is another entities. So when you look for the classification based on the marks or the ECG, strep or ECG, either narrow complex tachycardia, then wide complex based on the QRS width, less than 20 milliseconds or 3 small squares or more than 3 small squares. This is very important. Then you go for the second, the regular tachycardia or irregular tachycardia. So now we have two major arms. You will classify the arrhythmia or the tachyarrhythmia. Either narrow or wide based on the complex, then regular or irregular based on RR cycle lengths. And of course, when you identify the arrhythmia correctly, for sure, the second step, you will treat correctly. So what are the common arrhythmias you will encounter usually in the ICU? Of course, as you mentioned before, sinus tachy is the commonest, AFib, atrial flutter, SVT, conduction abnormalities with peripheral types, some from simple bradycardia up to a high-grade atrial block. Do not forget the wide complex tachycardia, which is the VTAC, or on the other hand, which is SVT with aberration, or we call it SVT with bond branch. Also, it will go under the differential diagnosis of wide complex tachycardia. Torsade de Pointes, we will say it a lot in the ICU because of acquired lung QT, and ventricular fibrillation. So case now for one patient, 28-year-old woman, 32 weeks pregnant. She had underlying severe mitral stenosis and NIHA class 3. Short referral, she got to the ER. She got an onset of rapid AFib. She was dyspneic, sedated, and intubated in the ER. Her MAP fell down to from 70 and admission 50 after intubation. And this was her EKG. From her EKG now, this rhythm is irregular. So the RR, if you look, this rhythm is a rhythm strip with irregular or unequal cycle lengths. There's no P wave, cannot identify P wave. And here as well, there is a remarkable segment depression here in anterior or anterolateral atrial fibrillation with rapid ventricular response. So the question is, the best prevention in this patient? A is to give Amidarone, 300 milligram stat, then infusion. B, electrical cardioversion immediately because the patient is hypotensive. C, heparin infusion as per protocol because we label it as atrial fibrillation. Or D, you will go for a stat echo. Usually we encounter this scenario frequently in the ER or in the ICU. So what you should do, this is one of the common MCQ questions. So either to give Amidarone, the patient is hypotensive. MAB, as I told you, it's 50. She's hemodynamically unstable. Are you gonna give her cardioversion now immediately because she's unstable, or because she had atrial fibrillation, you will anticoagulate her with heparin infusion, or you will order point of care stat echocardiography? So we need an answer. Okay. So one of our colleagues here ordered for an echo for this patient. He said, I will get Amidarone because the patient is already shocked hypotensive. I will not give cardioversion because I don't know where this atrial fibrillation duration, since when. It's long, it's a chronic, it's a paroxysmal, it's intermittent, it's permanent, we don't know. So she came to the ER with atrial fibrillation. She is now hemodynamically stable, intubated, they started pressors. But when they got the transthoracic echo, we were surprised with this, which is the huge left atrial mass or left atrial thrombus. So do not rush with your answer because she's hemodynamically unstable and you don't know about the onset of the atrial fibrillation. So please, with the point of care ultrasound, it can give you an answer. And this is what the answer. The patient had an left atrial thrombus. So the correct answer here is to order for a stat echo because it may give you a clue that this patient will not benefit from electrical cardioversion or heparin infusion in the management, because I will tell you later how risky is the electrical cardioversion, especially for patients with chronic AFib and underlying left atrial thrombus. So regarding atrial fibrillation, one of the most common disturbances that we encounter in the ICU, it's very tolerated. It's usually straightforward. Management is rhythm control or rate control. Rhythm control, just what does it mean? Rhythm control is to revert it back to sinus rhythm, whatever the tool or the mechanism or the intervention, either pharmacologic or electrical. Versus rate control, that you will use the pharmacologic rate control. Okay, so this is the management for strategies for the atrial fibrillation. For the atrial fibrillation, if you have unknown duration or onset of more than 48 hours, or the patient had a high risk for thrombus formation, if you look for the left atrium by transthoracic echo or transesophageal, then you found what's called, the cardiology, they call it left atrial smoke. So you have to order for the transthoracic echo, then follow up with the anticoagulation protocol. What about the controversies? Yes, we have controversies, either rate control or rhythm control, as I told you. The outcome is the same if you will return back to sinus rhythm, or just to the patient develop the atrial fib and go just for a rate control, no need for rhythm control. Both have the same outcome. Those concerns were addressed since a long time. This is one of the publication in 2002 New England Journal of Medicine. They compared the rate control, rhythm control in patient with AFib. This is one of the famous trials called Affirm trial. Another one, 2008, rhythm control versus rate control for AFib in heart failure patients. So till now, and another, the third trial in 2016 was the rate control versus rhythm control for AFib after cardiac surgery. So we had one in the Affirm trial, we have one trial in cardiac surgery patients or post-cardiac surgery, and one trial for heart failure patients. So till now, we don't have randomized control trial for ICU patients. Atrial fibrillation management and in ICU patients is a rhythm control or rate control as an outcome, or ICU length of stay. The association between atrial fibrillation and morbidity and mortality, there's multiple trials. We will talk later in our series. The quality of life potentially reduced if the atrial fibrillation is persistent or paroxysmal because of the sequelae or the complications. For the pragmatic approach, yes, for the atrial fibrillation. So commonly we have to address the underlying contributors, the hypoxia, ischemia, electrolyte imbalance, recent surgery, and attempt to cardiovert. If it's persistent or recurrent AFib, you have to change the strategy to rate control and anticoagulation. So this is what's called a pragmatic approach. This is commonly for critically ill patients. I'm not talking about the chronic AFib. So here for definition is clear. If you have persistent or recurrent AFib, so your strategy is rate control and coagulation. But if your patient had a paroxysmal or recent atrial fibrillation, so treat the underlying plus cardiovert. And here it depends, and the cardiovert is either pharmacologic or electrical. So this is electrical versus pharmacologic cardioversion, that they have the same risks. Electrical cardioversion potentially increase the risk of LA thrombus dislodgement. Still, we don't have an available evidence behind this, but still there is a reported cohort study, there is a reported case study. Both for carry at the electrical and pharmacologic carry at least some risk of thrombus dislodgement or new thrombus formation post-cardioversion. So call it the stand left atrium. So the anticoagulation prior to cardioversion, if applicable, this is if the onset of atrial fibrillation is unknown or more than 48 hours. We have current guidelines for atrial fibrillation, many guidelines. This is the latest one. What about the use of Amidarone in ICU? How much is too much? So when you ask people how much Amidarone you will give for cardioversion in the ICU, some people, they will answer you, we don't know, but you can give a lot. How a lot? How much? 1 gram, 2 grams, 3 grams. So the recommended is between 150 to 300 milligram as a bolus, then 40 to 50 milligram per hour infusion. Usually we use this approach, or we use this method of maintenance over 24 hours. Usually we load up to 900 milligram, then 1 milligram per minute over several days. Why? Because the Amidarone, sometimes you give 1 gram for 24 hours, but the patient is still in atrial fibrillation. So Amidarone, one of the medication that it needs to be accumulated, and we have a certain serum level. So some patients, they respond to 500 milligram of the loading. Some patients, they respond to 1 gram. Some of them, they need 2 or 3 or 4 grams. And those are the protocol. Usually we use it for the ICU. Usually we start with the loading dose, then we go for 1 milligram. This is what we use it for 6 hours, 1 milligram per minute for 6 hours. Then the remaining 18 hours, we go for 0.5 milligram per minute. This is the commonest, or to make it simple, usually the load with between 150 to 300 over 10 to 20 minutes. Then they go for 900 milligrams over 24 hours. This is the simplified algorithm, how to manage atrial fibrillation with rapid ventricular response. I just telling you that when you have arrhythmia, you have to have an approach in your mind, how to manage. Is it stable or unstable? Then you will go through the algorithm, when to cardiovert, when to use pharmacological approach, and when to maintain the sinus rhythm. Remember, you have to avoid the Amidarone in patients with pre-excitation, WBW syndrome. Avoid it in pregnancy and breastfeeding ladies. Avoid the patient with ego block or significant bradycardia. Avoid the patient with long QTC, more than 480, more than 490. So you have to avoid it because it's one of the medications that prolong the QTC. Also, avoid the use of Amidarone in patients with fulminant hepatitis or liver failure. And those are the 3 common complications, if you remember those photos very well. This is the thyroid gland, and the Amidarone, of course, it causes hypothyroidism. So this is one of the common hypothyroidism, drug-induced by Amidarone, or drug-induced hypothyroidism by Amidarone. This is the facial discoloration by Amidarone, and lung fibrosis. But remember, those for long-term use of Amidarone. This is very, very rare to encounter on acute basis or acute management of Amidarone. Those with people for years on Amidarone. What else after Amidarone for atrial fibrillation? Of course, to maintain the serum electrolytes within targets, and this is what usually we do in ICU when we have fibrillation. To target the common electrolyte, which is the potassium, between 4.5 to 5, magnesium 2 to 3. So those are 2 partners and playing an active role in the atrial fibrillation. Deltasm, blocker, this is for rate control. Else, failure of rate or rhythm control pharmacologically. So you may go for asking the electrophysiologist people to have the study and the so-called RF ablation for recurrent atrial fibrillation that is not responding to the anthemic, or the patient is developing a complication or side effects or adverse effects from the antiarrhythmics. What about the atrial flutter? Sometimes in the ICU or in the ER, it's difficult to diagnose the atrial flutter, or sometimes people mix it with coarse fibrillation. they mix it with coarse atrial fibrillation. So usually when you want to diagnose the atrial flutter, please look for the limb leads, lead 2, lead 3, and AVF. Those are remember, those are the best leads to have the so-called sawtooth appearance of the flutter waves. Lead 2, 3, and AVF. If the heart rate is regular and fixed at 150, please think about atrial flutter. So if the nurse call you that the patient suddenly develop rate of 150, let's see a P wave, and the rate is fixed at 150, please think about atrial flutter, ask for 12 lead ECG, and read it carefully, because this is one of the common rates and representing the atrial flutter, which is regular, and the rate is fixed at 150. When you have an auto-analysis of the ECG says sinus with first degree of block, look carefully for possible atrial flutter with 2 to 1. So this is one of the common mistakes that we found it, or we face it a lot, especially for the auto-analysis of the ECG. Manage as atrial fibrillation, as we mentioned, is stable or unstable, but the different protocol, we will highlight it in the management of the arrhythmias. This is how is confusing the atrial flutter with coarse atrial fibrillation. This is, remember, look carefully here for lead V1. You have coarse waves. It looks like a sawtooth appearance, but when you compare it to lead 2 and V5, it's not there. It's not available, or it's not present. So this is, we call it coarse atrial fibrillation. If it's an atrial flutter, or the appearance, the block ratio, 2 to 1, or 4 to 1, or 3 to 1. Just I go through, because of my time, about so-called the ventricular tachycardia storm. Ventricular tachycardia storm face it frequently in the ICU, or patients who have underlying ventricular tachycardia. So it's a diverse arrhythmic mechanisms, broad in definition. It's frequent episodes, VTAC or that require immediate cardioversion. The management guidelines rely on the evidence. Most trials define it as more than 3 episodes of VTAC, more 24 hours. So if the patient have recurrent ventricular tachycardia for more than 3 sustained ventricular tachycardia within 24 hours, they call it ventricular storm or electrical storm, rotative ventricular tachycardia. And those episodes usually are more frequent. And you remember here, this is one of the Holter monitoring here, recording in 6 minutes for patient who is having implantable regulator. Remember, sorry, you can see here, this is the sinus rhythm, frequent exosystole, then he start to have polymorphic VT, Dorsat du point, then he start to receive a defibrillation shock. This is one shock, one shock, one shock, one shock, one shock, another one. So this is from implantable cardioverter defibrillator or the ICD. So this is what we call it ventricular storm. So 3 or more sustained VT episodes within more than 24 hours, may be very difficult to manage with Amidarone, beta blocker as a first line. Risk benefits for the ablation, it needs an expert out of ICU, but for ICU management, usually you have to have a guideline or an algorithm to manage those patients. Otherwise, you will have a morbidity or even mortality because you don't have the proper way to manage the ventricular storm. So this is an example of the monomorphic VT or polymorphic VT. Another example for Dorsatopo VF. And these are the substrates or the triggers. If a patient had previous MI, myopathy, valvular lesions, neuroischemia, or channelopathy, for example, the Brugada syndrome. So this is the mechanisms behind the VT storm. VTOR storm etiology, as I mentioned, is totally unknown. Sympathetic hyperactivation is an underlying mechanism or one of the theories behind it. Heart failure decompensation, new ischemic events, electrolyte imbalance, triggers by ventricular ectose and theories or different mechanisms. So when you manage, you are playing on all of these mechanisms. So how to manage the storm? The arrhythmic drugs fail. Usually we go for sedation, general anesthesia, intubation, and general anesthesia just to knock her down. Propofol infusion, it reduces the sympathetic tone by inhibiting of course, the central sympathetic discharge. So we use it commonly when we face ventricular storm that not respond to anti-arrhythmic. Cardiac sympathetic denervation, this is a lung ablation and LVAD. This is management, but those are the short-term and ICU. The IV sedation and analgesia, but of course the intubation and admission to the ICU, infusion, plus a long-term plan with the electrophysiology people. Here I have to sum up to conclude my arrhythmia overview, and I apologize for the length time for my presentation. So management of arrhythmias in the critically ill patients, of course, is complex, and for this reason we need to have some safe and simple rules. Those are the 6 rules I conclude my lecture. Rule number 1. Remember, not all arrhythmias need to be treated. Number 2, electricity is generally safer than drugs. Number 3, correct all correctable factors or abnormalities. Number 4, treat all treatable ischemia or electrolyte imbalances. Number 5, when you have a central line or dialysis catheter and patient develop new onset arrhythmias, consider to review your intravascular access, even if it is over-penetrating or reaching the right atrium, residing the wall, or passing the valve and reaching the RV. So you have to review your catheter position. Number 6, remember and consider the broad of your drugs or drug toxicity. Thank you.
Thank you very much, Dr. Samir, for this extraordinary, excellent presentation. Sorry, Dr. Adel. There are actually a few questions, but because of the time restraint, I'm going to only ask you a couple of them. Dr. Adel, what do you think about treatment of VT in a pregnant woman? And if she doesn't respond to the DC shock, how we can deal with this patient?
So, of course, for my colleagues, I'm giving an overview about the ICU patients. For differentiation management, of course, will cut the 3rd lecture, but to answer your question, again, to go sub-basic, especially either pregnant or not pregnant, of course, I have to identify the rhythm before pursuing that. So I have to have certain criteria to assure that this is for sure it's a VTAC, not SVT aberration.
Yeah.
So I have rhythms, certain identifications that assure clue and TAC, not SVT with aberration, because the management, of course, is different. Regarding the stability, all of us, any unstable arrhythmia, and we will talk later about the definitions of what does it mean unstable. So unstable arrhythmia, usually the electrical cardioversion is the treatment of a choice. Putting in the of is an atrial or ventricular. The patient has A thrombus, L thrombus, for example. You have to be cautious before your cardioversion, unless it's life-saving. Okay. Regarding the antiarrhythmics and or pregnancy, so usually we relying on those short-acting safe for the baby itself. Of course, the termination with termination with procainamide is safer and or lidocaine. However, the recommendation for electrical diversion for pregnant lady. We have had meta-analysis a long time because this question was addressed. How safe is the electrical diversion for the baby?
Yeah.
Very, very few reported cases that for babies on the gestational age. But there was something came out from this and RCTs regarding indication.
Okay.
Once you life saving.
Yeah. Okay. Perfect. Thank you so much. I think we are now running out of time. There are so many questions in the panel, and there is huge interest from all audience about the arrhythmia. Myself personally, I find arrhythmia one of the most difficult and challenging, things to treat and to read the ECG. So thank you so much for this excellent presentation. I would like to thank all the speakers for today. Dr. Samir Al-Ansari, thank you so much.
Thank you very much.
Dr. Zaghloul, thank you so much. Your presentation was more than excellent. We really enjoyed the polytrauma patient, and I think you will have a homework for tonight. Multiple questions in the Q&A, and please answer these questions if possible. And Dr. Adel Hussien, thank you so much. Dr. Saad Mahdi, many thanks for your effort.
Thank you.
Our audience, thank you so much for attendance today. It was great attendance. We hope to see you again in the next session in our online anesthesia mega course, and have a very good night for all of you. Bye-bye.
Thank you. Thank you very much.
Bye.
Thank you.
Bye-bye.
Thank you. Thank you.